Okay, so very good afternoon to everyone watching us live from across the globe. As we know that we are all here for a webinar on sequencing of EGFR TKIs in the management of NSCLC and case-based discussion on management of squamous cell lung cancer. This is being organized by International Association of Oncology and is being supported by BI. So without much delay, we would like to introduce our speakers for the afternoon, starting with Dr. Biswas sir, who is a medical oncologist at Tata Medical Center, Kolkata. We welcome you, sir, to the webinar. And we have Professor Dr.Srikrishna Monda, sir, who is the professor and head of Department of Reg. Start your presentation. Over to you, sir.
Sure. Thank you. Thank you for giving me this opportunity to the organizer and the BI. So in between, you can just display my slide. Yes. And thank you, sir, Professor Srikrishna Monda, to be present in this webinar.
Okay, welcome, Dr. Biswas.
Sir, is this your slide?
Much time will directly go to the. Yes, sir, I can.
Sir, can you just click on next and see whether you can change it from your side? Can you click on next?
Yes, yes, it is happening.
Okay, sir, you can start.
Yes. Yeah. Okay, thank you. So very good evening to everyone. Now the sequencing in EGFR TKI is very much important, as you all must be aware that over the last few years after the first and second generation TKI, we have many more options. In it, so we have new drugs in the 1050 decomotinib. And other than single agent EGFR TKI, we have combination options available, chemo plus TKI, combination, the NEG006, and the data from the TMH Mumbai also showed that PFS and OS advantage with the combination regimen. We have allotinib plus bevacizumab also showed PFS and OS benefit. We have now the latest is the relay data with allotinib and ramucirumab also shows PFS benefit. The OS data is yet to come. So we have almost 5 TKI, 3 combination.
ওকে আগে ফোন করে বল
lung cancer.
বলে দিলাম একটা কাজ যদি হয় আমি একটা কি
So it is very important to optimize the use of TKI, especially in a research poor setting like India. And when you are planning to invest TKI, how you want to sequence that is also very important. So we'll move to the next slide. So what will choose when you choose a TKI for any patient?
তুই একটুখানি শুনে নি, তুই খোঁজ নিয়ে আমাকে জানা যে এইমস এর ওই নিউক্লিয়ার টার্গেটেড থেরাপি ফর প্রস্টেট ক্যান্সার যদি হয়।
Sir, can you mute yourself, Srikrishna sir? Your voice is audible.
So can you mute your audio for a minute?
Yes, I think it's mute. And what to do in a subsequent treatment, whether presence of brain mets is not there. So these are the scientific and ethical aspect when you're choosing a TKI. But I think other than these, 2 other important factors, especially in our setting, is that what the patient wants, depending on access to care, cost of the treatment, efficacy you already discussed, and the safety profile. And always it is a challenge in a resource poor country, in a LMIC country, the access to care. Not all patient can afford a base standard of care. So where the sequence is very much important, I must say it is an optimum use rather than a proper sequencing. So these are the published literature so far about allotinib, gefitinib, and afatinib. Other than these, we have decomotinib, Archer 1050. We have FLORA data with osimertinib. So if you see the PFS benefit, PFS with the first generation TKI is in the range of always 9 to 10 months. With the allotinib around 10 to 11 months. With the afatinib around 11 to 13 months. We have the best of PFS with osimertinib around 19 months, 18 to 19 months. Then we have decomotinib 14 to 15 months. So these all TKI are different in terms of efficacy. So what is the evidence that this TKI is not equal? So first generation is the reversible TKI, second generation the irreversible one, third generation is also the irreversible one. And among these, the third generation has a very good CNS penetration. And this is also inhibit T790M. First generation TKI doesn't inhibit T790M. Second generation has some affinity towards T790M, though they are inactive in a therapeutic level for T790M mutation. So this is the curve. You see the EGFR mutation, gefitinib, afatinib, and the osimertinib. But if you see the T790M, it's mostly active with osimertinib, even than the common EGFR mutation. It is not sensitive to first generation TKI because the amount of concentration of the drug that inhibits the T790M is not tolerable dose. Same with afatinib, the afatinib, or in the sense of dacometinib also, they do not inhibit T790M. Now coming to the toxicity profile, if you see the wild type EGFR, these all TKI to some extent block the wild type EGFR, that is causes the symptom, that is the skin rash, erythroderma, loose motion, nail changes. Gefitinib has some effect to the wild type. Afatinib has a greater effect to the wild type than the first generation TKI. That's why this is more toxic among all three regimen. On the other hand, osimertinib has a very least effect to the wild type. That's why they're the safest TKI in among all kind and the least toxicity profile. So these are the other toxicities. They have interaction with the CYP3/4 inhibitor, has the gastric acid secretion. So you have to be careful when you're using first and second generation TKI, and also third generation, that should not be any the drug inducer, enzyme inducer or inhibitor. And the use of PPI use. You cannot use PPI when you're using first and second generation TKI. But I think with osimertinib that is not a problem. So this is in terms of efficacy, as we discussed, is they are not equal. If you see the afatinib, the Lux-Lung study showed longer PFS and time to treatment failure and overall response as compared to gefitinib. Dacometinib study also shows longer PFS, no differences ORR, but there are also OS advantage. Osimertinib has a longer OS, longer PFS, but no difference in overall response. So they are slightly different in terms of endpoint and also the magnitude of benefit. So safety wise also the second generation TKI, both afatinib and dacometinib, the highest toxicity with a more skin toxicity, loose motion, nail changes and transaminitis, followed by first generation TKI, that is the gefitinib, and the least toxic is the osimertinib. So these are the overall survival advantage with all types of TKI. Afatinib shows in the Lux-Lung study they failed to show it in OS benefit because of the trial design. There's a three primary endpoint, but if you see the combined analysis of the Lux-Lung, this is the combined analysis that shows the OS benefit. Allortinib, gefitinib could not show OS benefit because they were the comparator was chemotherapy, and most of the chemotherapy patient who progress upon were given to the first generation TKI. So because of the crossover, this TKI failed to show any OS benefit. On the other hand, the Archer study and the Flora study both showed OS benefit. So coming to the subgroup analysis, DEL19 and L858, these are the two most common EGFR mutation. If you see the Lux-Lung study, DEL19 subgroup, the PFS is, this is the OS data of 33 months as compared to 21 months with chemotherapy. Coming to the Lux-Lung 6, almost similar, 31 months of OS with as compared to 18 months with chemotherapy. So both the subgroups shows very good OS benefit, almost hazard ratio is around 0.5. Definitely it is impressive as compared to chemotherapy. So this is the entire cohort, the OS 39 versus 25 months. If you see the TMS data, the control arm was gefitinib, the median OS was 17 months. So maybe an Indian patient, they are less sensitive to first generation TKI. Now exon 19 deletion subgroup, again, it was, excuse me, the outcome was much more pronounced, 48 months of. These are the subgroup analysis with a lesser number, so could not discuss too much. But anyway, subgroup analysis, the DEL19 shows a better outcome as compared to the whole population. Uncommon mutation also, there was 10% patients uncommon mutation that also showed very good benefit as compared to TKI. But again, this is a very small population. We cannot talk too much from a subgroup analysis. L858R group, we always know that they are slightly inferior in terms of PFS and OS as compared to DEL19. So even with afatinib, the outcome was 25 months of median OS and not much of difference from the first generation and the comparator group. Coming to the uncommon mutation, this is one of the challenge. More with the use of more of DTPCR or NGS, we are detecting more of the uncommon mutations. So what are those uncommon mutations? They are exon 21 L861Q. We have exon 20 insertion 768I. We have G719X, that's the exon 18 insertion. So these are the most common uncommon mutation. The majority of the uncommon mutation, they happen as a compound mutation with either del19 or L858R, but very rarely they can happen in isolation also. So in general, 8 to 10% of the EGFR mutation is uncommon mutation. They are not that much sensitive to first generation TKI. So whatever data we have is from the second generation TKI, mostly afatinib, and there are some study also on osimertinib. So we'll discuss what is the current data of TKI in uncommon EGFR mutation. So these are the different subtype and the sensitivity to the TKI. If you see the waterfall curve, that shows shrinkage with afatinib in the LUX-LUNG study. So these are the subgroup analysis. G719X, that is the most common, median PFS of 13.8 months, median OS of 27 months. L861Q, median PFS of 8 months, median OS of 17 months, and then S768I, again a good PFS, 14.72 months. So though these uncommon mutation, they have a better PFS and better OS as compared to TKI. When you use second generation TKI, particularly, the data exists for afatinib only as of today. So these are the different types of mutation and their Kaplan-Meier curve with afatinib. There is one study, I think it is a Korean study from for osimertinib. There is a 37 patient study of osimertinib in uncommon mutation. Overall response rate of 50%, median PFS of 8.2 months, and duration of response of 11.2 months. So osimertinib is also active against uncommon mutation, particularly these three mutations. So now coming to the brain metastasis, if you see the LUX-LUNG study, those patients who does have brain metastasis, they have a lesser number of CNS progression as compared to extra CNS progression. And those patients who did not have any baseline brain metastasis, their CNS progression was very less. If you see the CNS progression 6.4% versus extra CNS progression 78%. So that means afatinib has some amount of CNS penetration and activity, and they are much more effective and their efficacy is much more better in patients with those who didn't have any brain metastasis. To be noted that all the LUX-LUNG study has allowed patient with a stable brain metastasis. On the other hand, the Archer study did not include any patient with a brain metastasis. So risk of CNS progression, patient without brain metastasis, we have already discussed. It is effective, and so those patients who received afatinib followed by osimertinib, what happened to them? 10% patient has a brain metastasis as baseline when started on afatinib, and out of this, 8 patients did not have any brain mets when they are progressed. So that means they may have responded either to the drug or to the whole brain RT or CNS-directed therapy or both. But when they progress, 12% patient has brain mets when they started on osimertinib, and 6% patient has new brain mets while on osimertinib. So this is geotac study. This study was it's a kind of a prospective study, a non-randomized study, singular study from many centers in the Asia where patient received afatinib as upfront, and when they develop T790M, if they receive at least 10 months of osimertinib, it is their data. So these are the very selective subgroup of patients who receive afatinib, develop T790M, then receive osimertinib at least for 10 months. For them, if you see the median time to the brain metastasis was 28.4 months as compared to the placebo. So delayed onset and progression of brain mets when treated with osimertinib, that you always know this is the only TKI with the greatest activity in the CNS, both in terms of treatment and also in terms of prevention. So this is the afatinib versus first generation TKI. So CNS progression was least with osimertinib. So why they progress? This is the mechanism of resistance to first and second generation TKI. You know that most patients will develop T790M in 40 to 60%, maybe more in Asian patient, but in Indian setting, the T790M ratio is approximately 45 to maybe 50%. Out of this, except the T790M, there are many patients who develop HER2 mutation, PIK3 mutation, small cell or squamous cell transformation, and also MET amplification. These are in a nutshell. But even after doing all this, 30 to 40% patient will have no identifiable or targetable mechanism of resistance. So it is very imperative to check all patients when they progress first generation TKI, what is the resistance mechanism, because your subsequent line of treatment will depend on the types of resistant mechanism. So this is the AURA3 data. We know the median PFS phenomenal, 10.11 versus 4.4 months with chemotherapy, and the hazard ratio is 0.3. Though unfortunately the final OS analysis in this study failed to show any OS advantage in favor of osimertinib. That may be the reason, because most of the patient from the chemotherapy arm, when they progressed, was shifted to osimertinib. So because of the high crossover, whatever the PSA benefit was there was blunted with the crossover. So what is the latest, what is the molecular mechanism of the osimertinib? The data is not that mature, because we have only a few data from the AURA3 study and the most data from FLORA study. But what we know as of now, that 30% patient, the 10 to 15% patient develop secondary EGFR mutation like C797S. Then 30% patient, 20 to 30% patient may have a secondary MET amplification. Around 4 to 10% patient may have a small cell transformation. More small cell transformation has been happened to the osimertinib than first and second generation TKI, and another 10% may have HER2 mutation and PIK3. So almost 50% patient have a identifiable resistant mechanism after osimertinib. No approved drug in that part say as of today, but there are many clinical trials currently ongoing for, especially in the MET inhibitor and also with the C797S. So very soon, the early result is very promising. So very soon we'll have some data on that aspect too. So these are the aqua resistant mechanism for the first and second generation TKI from the FLORA. We have already mentioned. So why sequence is important? We know that osimertinib is one of the standard of care, but if the patient progress very fast, then we do not have very much effective therapy other than chemotherapy and osimertinib group. On the other hand, if patient receive first and second generation TKI, if they are lucky, after the maximum or optimum PFS, they may develop T790M, and again you can use osimertinib. But the problem happens if they don't develop T790M. So that is one of the caveat or pitfall of sequencing. But whatever the data is there from the retrospective or the real world study, that 60% patient may develop T790M upon use of second generation TKI, particularly afatinib. So if your patient is lucky, the patient may develop T790M after afatinib, and you can try with osimertinib. So these are the things. First, of second generation TKI, T790M, use osimertinib. When fail, you can use chemotherapy or any other clinical trial where there is a identifiable osimertinib resistance. If there are T790M resistance, definitely they have to have chemotherapy. On the other hand, you have to check for MET or HER2 MET amplification, HER2 mutation, and if it is there, you can challenge with possible target therapy against those. And on the subsequent line, you may use immunotherapy, though they are not very sensitive to immunotherapy. On the other hand, if you use osimertinib, if they progress, you can use chemotherapy, and on the same side, you can identify the potential target like the MET amplification, HER2 mutation, or PIK3, or other rare mutation. You can put them on the MET inhibitor or any other clinical trial. And when they fail, again you can use immunotherapy either in single agent, or you can use the IM power 150 data. Excuse me. So OS in patients with limited access to subsequent osimertinib in the LUX-LUNG study, 31.6 months with afatinib, 28 months with chemotherapy, and the DEL19 group, 33.3 months versus 21 months. So definitely it's a one of the active agents, especially in DEL19 subgroup. So this is the overall survival in the GeoTac study. As I said, it's a retrospective real-world study who received subsequent afatinib followed by osimertinib. The outcome is very good. Median OS is 41.3 months. But these are the very selected subgroup. This is the FLORA data. What is the subsequent therapy? If you see that 1/3 of patients could not receive subsequent therapy, other received either chemotherapy or other clinical trial treatment. So that means even in the osimertinib group, 1/3 patient may not receive second line treatment. The same real world data we have seen with the first and second generation TKI that up to 40 to 60% patient did not receive second line therapy irrespective of T790M. So we do not know which patient is going to develop T790M, whether they remain fit to receive subsequent line of treatment. So it is when you are choosing a maximum or the optimum sequencing, you should keep this in mind that you do not know which patient is going to develop T790M and who is going to receive subsequent therapy. So in that sense, if you are in a doubt, it is better to use the best active agent, that is the osimertinib. So this is again the same data from the Asian study. There's a Japanese subgroup analysis, very good data as expected. So putting OS's context, this is the first generation TKI around 20 to 28 months. First generation TKI who received osimertinib is 32 months. This is from the AURA3. Then afatinib 30 to 38 months. We have dacometinib Archer study 34 to 37 months. Osimertinib so for 40 months, and the geotac study, that is the afatinib followed by osimertinib. This is not a prospective randomized study. This is a single arm retrospective study, the best outcome. But again, this is the selected subgroup. And we have combination therapy, excellent outcome from the Japanese study, but we have hardly seen this outcome even in India study. We have Bay-Varlo combination, very good OS, but they failed to show any benefit as compared to single agent TKI. We do not know the reason why. And we have latest Arlo to Ramusumab, the OS data is yet to come. So I think this is my last slide. I will stop here. Thank you.
Thank you so much, sir. So should we move to our next presentation, sir? The second one?
Yeah, sure.
Is this the one, sir?
Yeah.
Sir, can you just click on next and see whether you can change the slides?
Now you will change the slides.
Okay, sir. So once you are done with presenting one slide, you can tell me next, and I'll change.
Okay. Okay. So one thing is that during introductions you just made a bit mistake. I am working in N.R.S Medical College, Kolkata, as HOD Department of Radiotherapy. I am ex-PGI definitely, but now I am working as a HOD Department of Radiotherapy, N.R.S Medical College. So what I am going to tell today, that is success and challenges in treating squamous cell carcinoma of lung. Actually, for adenocarcinoma, that is so many targeted therapy, but for why we are treating the squamous cell, it is difficult. So till today, till date, there is no such targeted therapy available. But nowadays, few trials are there who have done a good result in squamous cell carcinoma also. So we are just going through those trials which had a better result in treating squamous cell carcinoma lung. Next. Just I will go through this outline of success and challenges of the squamous cell carcinoma lung. Immunotherapy in the second line has been standard care in squamous cell carcinoma. With recent data, immunotherapy, that's either this monotherapy or combination, has become a first-line treatment option. Few trials, we'll discuss few trials, the Keynote 407, Empower 131, and Checkmate 227 in subsequent slides. Big progress is seen in second line for squamous cell carcinoma after immunotherapy. And what will be the challenges? I've discussed the challenges. It's just like dysregulation in ERB pathway, apatinib, and complex genomic alteration in lung cancer, squamous cell carcinoma. Priority in the first line when immunotherapy alone or in combined with chemotherapy, that will be discussed in later few slides. What are the options after first line failure of immunotherapy plus minus chemotherapy? Next. Success. Next. This is few trials. I will tell you. Big progress in the second line therapy of squamous cell carcinoma, which will be shown in the few trials. Just this Checkmate 017 trial it is with nivolumab versus docetaxel, checkmate 078. It is nivolumab with docetaxel versus docetaxel. Keynote 101 is pembrolizumab versus docetaxel. And Rebel trial is a very good, having a very good result. Ramucirumab plus docetaxel versus docetaxel alone. And last one is a last line trial, that is dapatinib versus erlotinib. And what we have seen, the median PFS, it is 3.5 months in checkmate 017 versus 2.8 months. All have shown a better result in nivolumab or nivolumab pembrolizumab, but very good result is seen in Rebel trial, that means ramucirumab plus docetaxel group is 4.5 months versus 3, and also in Lux Lung 8 apatinib versus erlotinib with a 2.6 months versus 1.9. And also when we are talking about HR or median OS, it is seen that this checkmate 017 trial has a very good response, 9.6 months versus 6 months, and also checkmate 078, that is also very good, showing very good results, 12.3 versus 7.9, and keynote 010 having showing a very good result, 14.9 months versus 8.2 months. And lastly, what I can tell you, this last line 8 month, that means apatinib, that it is seen that 7.8 months versus 6.8 months. Next. So immunotherapy has been the first line in squamous cell carcinoma lung. If we analyze these trials, that means keynote 407, histology Empower 131 and checkmate 227, all are first two, that is keynotes 407 Empower 131, histology is squamous. And in checkmate 227, it is a mixed histology, that is squamous with mixed. So what the treatment is given in keynote 0.7, pembrolizumab with chemotherapy versus chemotherapy. And Empower 131 has a one arm A, arm B, atezolizumab carboplatin paclitaxel, atezolizumab carboplatin nab-pacli, and C carboplatin nab-pacli. But in checkmate 227, it is PDL1 is equal to or more than 1%, or PDL1 is less than 1%. It is part 1A and 1B, and PDL1 less than 1, it is part 2. That is nivolumab chemotherapy versus chemotherapy alone. So if we analyze these trials later on, what will we see next? It is seen this keynote 407 OS, that means pembrolizumab with chemotherapy versus chemotherapy, it is definitely significantly higher OS is seen in pembrolizumab combination arm, pembrolizumab combination arm in comparison to placebo arm. That will be about 15.8 months in comparison to placebo arm, that is 11.3. Next. Empower 131 study design, it is included stage 4 squamous cell lung cancer, non-small cell, chemotherapy in prognosis status 01, any PDL1 IC status, stratification 6, PDL1 IC, and liver mets. Arm A, Arm B, and Arm C. Here 1:1:1 ratio patients are taken. Arm A atezolizumab carboplatin paclitaxel, Arm B atezolizumab carboplatin nab-pacli, and Arm C is carboplatin nab-pacli. What is the primary and secondary endpoints? Primary endpoints investigator assess PFS or OS, and secondary endpoint the PFS and OS in PDL1 subgroup, ORR and DOR, and receptive profile. Next. And what is seen? PFS benefit in patients regardless of PDL1 status is seen in arm B and in comparison to arm C. It is a median PFS. It is seen. It is seen that 12 months PFS is seen in 24.7% cases in comparison to arm C, that is only 12%. That means it is and arm B it is 6.3 months comparison to 5.6 months median PFS. And OAS, no OAS benefit is seen in patients regardless of PDL1 status. It is both the arms have more or less similar results. Next. And in Empower 131 final overall survival in PDL1 high subgroup arm B versus arm C, it is seen that in B, that means atezolizumab and carboplatin and nab-paclitaxel group. Median OS is 23.4 months. That in comparison to arm C, that means carboplatin and nab-paclitaxel, that is 10.2 months only. So it is in PDL1 high subgroup, this arm B, that means addition of atezolizumab have a very good result in comparison to non-atezolizumab group. Next. And checkmate 227 part 1 study design. Here the stage 4 recurrent stage 4 or recurrent non-small cell lung cancer taken, no prior systemic therapy, no known sensitization to EGFR alteration, ECOG, performance 1 is taken. Here, this patient is taken in two groups, and this PDL1 expression more than or equal to 1% and less than PDL1 expression less than 1%. These two were both the 1:1:1 ratio have taken, and here in PDL1 more than or equal to 1 subgroup, nivolumab, ipilimumab, and histology-based chemotherapy plus nivolumab. These three subgroup has taken, whereas in PDL1 less than 1% subgroup, nivolumab, ipilimumab, and histological-based chemotherapy and nivolumab, histology-based chemotherapy. Three arms are taken. So, and what it is seen? Secondary endpoint is definitely primary endpoint is OS, and secondary endpoint is nivolumab chemotherapy versus chemotherapy. Then PFS, it is seen in PDL1 less than or more than 1% cases. So next. So what is seen? What is seen? It is seen from this checkmate 227 part 1 study that PDL1 where expression is equal to or more than 1. The result is ipilimumab, nivolumab versus chemotherapy versus nivolumab. It is seen that nivolumab plus ipi result is 17.1 months. That median OS, that is very good result seen in PDL1 more expression equal to more than 1%. But in case of PDL1 less than 1%, it is also 17.2%. This is seen, and all randomized patients, it is also the same. This is 17.1%. Next. Checkmate 227 part 1 PFS analysis by tumor histological type. What it is seen, that is squamous histology, tumor histological, where this histology is squamous type. This nivolumab arm has shown a very good result, that with 36 versus 7 in comparison to chemotherapy alone. So, and in non-squamous, it is also shown. That means when this histology is non-squamous, the result is much more good, and it is also 46 versus 17 in comparison to chemotherapy alone. Next. What are the challenges? Challenges to unsolved issues with lung cancer, squamous cell carcinoma. Next. Should gene testing be considered first as is done for adenocarcinoma? Next. NCCN guideline. NCCN guideline shows, NCCN guideline for molecular testing is recommendation is that this squamous cell carcinoma molecular testing consider EGFR mutation and ALK testing is in never smokers or small biopsy specimen or mixed histology. In these cases, the molecular testing is done. Consider the ROS1 and PrEP testing in small biopsy specimen or mixed histology. Testing should be conducted as a part of the broad molecular profiling, and PD-L1 testing category 1 is recommended. Next. These regulations of the ERB pathway, a potential therapeutic target in squamous cell carcinoma lung cancer. These regulations of ERB pathway is frequently observed in squamous cell carcinoma of lung. EGFR overexpression and gene amplification aberration of the ERB receptors and dysregulations of the downstream pathways have been implicated in these pathobiologies of squamous cell carcinoma lung. EGFR overexpression is seen in 26 to 86% cases. EGFR amplification in 15 to 20%, 27% cases. And ERB mutation or amplification seen in 5% cases. ERB3, ERB3 mutation is only 1%, but ERB3 overexpression seen in 10% of cases. So these are the according to NCCN guideline, this recommendation when it is recommended, EGFR this testing is done, and this type of frequency, of mutation or amplification is seen in case of squamous cell carcinoma. Next, apatinib. Next. We're not talking about the apatinib. It is previous one. Apatinib is the first irreversible ERB family blocker. Apatinib is such a molecule. It is the first to irreversibly block the ERB family pathway. Apatinib covalently binds and irreversibly blocks the EGFR, HER2, and ERB4 pathway. Targeting the whole ERB family enhances the effect of important signaling pathway. The apatinib is that type of molecule who can do this, who can block this ERB pathway irreversibly. Next. Next. LUX-Lung 8 study design. What the LUX-Lung 8 study shows that it is taken the advanced squamous cell carcinoma stage 3 or 4 lung cancer. We have after 4 cycles of the first line platinum doublet, ECOG 0 to 1, no prior anti-EGFR therapy, and no active brain mets are taken in LUX-Lung. Randomization 1:1 is taken. Apatinib versus arlotinib. The treatment until disease progress or unacceptable adverse effect is still. Stratification East India non-Asian group. Tumor tissue collected for relative science, radiographic tumor assessment at baseline, and week 8, 12, 16, and on subsequently after 8 weeks thereafter. Primary endpoint is PSF and key secondary endpoint is OS. Next. LUX-Lung 8, what it is seen that afatinib when it is seen 40 milligram OD dose and allotinib 150 milligram OD dose, it is seen that afatinib has a better PFS and OS both are in comparison to allotinib. Next. ERB mutation, ERB wild type, when 22% of the patients in TGA had ERB mutation, it is seen that ERB wild type is seen in 78.4% cases, but ERB mutation is seen only in 21.6%. EGFR HER2 and HER3 mutation is seen only one patient, so two patients that had HER2 and HER4 mutation. So maximum is seen ERB wild type gene expression. So next, and it is seen that PFS and OS were longer in patients with ERB mutation positive, ERB mutation positive tumors versus those without the ERB mutation. And in PFS, both in PFS and OS, both are high in case of afatinib. When it is PFS in PFS afatinib 4.9 months median PFS versus 3 months, and allotinib is a 2.7 versus 2.4 months. But an OS in afatinib versus absent, it is afatinib versus absent 10.6 months versus 8.1 months, and in allotinib it is 7.2 versus 6.4 months. Next. Challenges 2, that means mono or combination. What will be the answer? Next. It is the squamous histology, current study and guideline recommendation for the first line squamous cell carcinoma. It is in the primarily preferred options in PDL1. PDL1 expression is there, and carbo plus cisplatin, carbo or cisplatin plus paclitaxel will be recommended in PDL1 less than 1% cases. Next. Challenge 3. Treatment option after failure of immunotherapy and chemotherapy. What will be the treatment option if chemotherapy and immunotherapy fail? Role of resistant mechanism after immunotherapy failure, and role of anti-angiogenetic, analotinib. Role of analotinib is there, and role of afatinib is there. So next. And it is seen that in case of analotinib versus placebo, it is seen that a good result that is median overall survival 9.6 months versus 6.3 months in case of analotinib. And when it is a progress-free survival, it is also analotinib as is median PFS is 5.4 months versus 1.4 months only. So in summary, what I can tell about the success, the weak progress of immunotherapy in squamous cell carcinoma lung, both in first line and second line setting is seen. Challenges can be met by squamous cell carcinoma in treatment. Should gene testing be considered first? It is seen that gene testing can be done. Priority in the first line immunotherapy is the first line setting. Monotherapy or combination. Later line treatment options after failure of immunotherapy and chemotherapy is limited. And what are the opportunities? These opportunities remains the patients with ERB mutation positive tumor showed a more pronounced PFS and OS benefit with afatinib. Need for treatment options such as afatinib after first line immunotherapy and chemotherapy in patients who have failed previous treatment with chemotherapy and immunotherapy. In patients who are not eligible for immunotherapy, these are the opportunities which we can have till today. So, thank you. So, I can finish my talk with this. Over to Dr. Manoj.
Thank you so much, sir. Should we move out to our third presentation, sir?
Yes, you can.
Okay, so thank you, sir, for this beautiful discussion on the non-small cell lung cancer. So this is the last talk. We'll like to be brief. We have 10 minutes time. So lung cancer is a unique area in a COVID-19 cases because we know that respiratory tract is an initial point of entry and most complicated part is the respiratory tract. So lung cancer is a unique challenge during COVID-19. All the patient has already lung is compromised because of the advanced stage or the early stage cancer. Its treatment on the top of that, if they develop COVID they become complicated, then the chance of morbidity and mortality high. So lots of panic has been happening at the initial part of the pandemic. Lots of professional bodies has elaborated guidelines how to manage, what is the optimum treatment strategy, what to give, what can be withhold or defer, and what should be given, or what we can avoid during the treatment of lung cancer. We have also published our Indian guidelines in the IGMP in the month of May how to treat a lung cancer patients in the Indian setting during the COVID-19. So these guidelines has taken the view that most of the treatment, as I said, the lung cancer patient all are immunocompromised, the lung is compromised, so the chance of morbidity and mortality is high. On the top of there's a treatment-related myelosuppression or the decline in immunity that also contribute to the chance of infection and the morbidity and mortality. So the guidelines was pointing in that view that we need to do an optimum treatment by means that we should give such type of treatment where the outcome even optimum and there's a less chance of catching infection or complication from the COVID-19. But what we have seen that we have done a survey in the initial patient about their perspective on lung cancer treatment, and we also published the result in JCO Global Oncology. What we have found that majority patients actually want to continue cancer treatment. For them, it is a fear of cancer progression or cancer-related death than the COVID that kills them. So most of the patients still opted for the ongoing treatment during the pandemic. And what we have learned over the last couple of few months, including the COVID-19 cancer consortium data, that cancer treatment per se is not causing too much of problem. Whether the patient treated received or not received chemotherapy doesn't make any difference. So we can safely give treatment during them. But yes, you try to optimize the visit for patients, those who are on follow-up, to decrease the hospital visit and to how to treat the early stage. So this is with the background. I will quickly go through this presentation, how to handle. So these guidelines is not a full proven, not validated. These are the optimum guidelines from the expert recommendation from the professional body and the medical surgical radiation oncologists who treat lung cancer, what they feel that this should be the optimum treatment. And this is the ever dynamic field. The guidelines is changing every day. So this is the COVID-19 coronavirus. This is the SARS-CoV-2 specific strain that is causing this COVID-19. These are the neuraminidase spikes that causes the mostly this coagulopathy. So I'll not go too much detail in the how the COVID is infected, how they spread. So cancer patient in the SARS-CoV, what is the importance? The initial report from the China and Italy showed that the chance of infection is much more in cancer patient than in a non-cancer patient. And out of them, mostly had a lung cancer. And they have a higher morbidity and mortality. So lung cancer in a previous time is just a platinum-based chemotherapy, but time has changed. Over the last decade, we have lots of targeted therapy, immunotherapy, personalized medicine, sequencing, combination. So now it's not just a straightforward cases, and each and every drug, either it is a target therapy or chemotherapy, immunotherapy, is a different type of toxicity profile. So we should be aware of the toxicity profile so that we can diagnose early. When a patient with lung cancer comes to casualty with a fever, breathlessness, and tachypnea, we should be knowing whether this patient is a chemotherapy toxicity, whether this patient having some infection, whether that infection particularly is a COVID-19 or something else, and whether this is a drug-induced pneumonitis more so common with immunotherapy. And all this symptomatology and the signs and symptoms is very overlapping. So it's very difficult to identify as a pinpoint single cause at a first point of contact. So these are the different guidelines in terms of decision criteria, treatment goal, status of the oncological disease underlying, whether it is a curative, palliative, active or ongoing treatment, risk of recurrence, therapy, catching of COVID-19 infection, and if someone is already COVID-19 positive as a past infection. So this is an important to customize their treatment. So these are the ASCO recommendation for COVID-19 positive or suspected patient. Anti-cancer therapy should be continued as planned. Clinician decision should be individualized after discussion with the patient. COVID-19 affected center where chemotherapy break can be given those where chemotherapy maintenance chemotherapy is not that much helpful, or you can switch from injectable to oral chemotherapy. Preferring oral chemotherapy, non-myelosuppressive over the other therapy. More judicious are liberal use of growth factors, and less frequent dosing like immunotherapy dosing. We have a 2 weekly versus 4 weekly, 3 weekly versus 6 weekly, so that there's a less footfall in the hospital, less hospital visit, and less chance of infection. So these are the broad category. So these are the different types of management for stage 1, stage 2, stage 3. For stage 1, if the patient is fit, you can defer surgery, especially those with a nodule less than 2 centimeter. For stage 2, stage 3, you can delay post-op chemotherapy by 3 months, and you can avoid those area of patient where the chemotherapy is not that much indicated or the benefit is less, but the risk is high. Neoadjuvant chemotherapy can be given to delay the surgery because the surgery in lung is a aerosol generating procedure, and especially in a patient with a morbidity and old age, whether we can delay the therapy. For stage 3, hyperfractionated RT, so that the treatment schedule become less duration. No constellation chemo, this is also not a practice nowadays. You can delay concurrent chemo RT, or you can use sequential for a borderline fitness patient. You can give 3 weekly chemo instead of weekly chemotherapy. For stage 4 patient, you can stop immunotherapy if they are responding. You can stop maintenance therapy if there is a good response. You can increase the immunotherapy schedule, or you can choose more of a target therapy where the option exists. So these are the broad-based guidelines for lung cancer management. For limited disease, curative disease, we suggest that you should continue the therapy, optimum therapy, with a different schedule of treatment, the short schedule. For the extensive stage, you can, for a small cell, you can orally tiposide after the induction chemotherapy or maintenance immunotherapy. You can do it 4 weekly in case of 2 weekly. So these are the things you can do, customized manner. Coming to the ESCO recognition, this is also almost similar. Telephonic or wave consultation for patients who are on follow-up, only consultation. Identification of the patient with flu-like symptoms and induction of patient mass gathering in a waiting area. So triage is very important in the casualty area. Discuss the benefit and risk of palliative and maintenance therapy and options of therapy holidays in between. Those, especially those who are doing well. Options of regimen and schedule that reduce the number of hospital visits, almost similar. Shorter hyperfractionated course of radiotherapy, delay surgery. So these are the things that you can do. You can do all the supportive care at the home or the community center rather than in hospital, like the blood transfusion. So you have to prioritize whether high priority, medium priority, low priority. Low priority is patient where the patient is stable enough. Very early stage, elderly patient with the chance of benefit from therapy is not that much high. And patient under a screening procedure, that can be slightly delayed. Medium priority where patient is non-critical but you cannot wait too much, so you can use a sequential or a longer duration schedule of chemotherapy, shorter schedule of radiotherapy. High priority where the most patient is curative, fit patient, and where you believe that this treatment is very much important, whether the gain in life is more. So you have to prioritize and the decision. All the decisions should be customized after discussion in details with the patient, including taking into consideration their choice of therapy also. So like the outpatient priorities, high priorities, a digital symptom, dyspnea, pain, name of disease. You cannot, you have to treat them. Suspicion of the high stage disease. Medium priorities, new diagnosis lung cancer of a clinical stage 1, post-op patient, follow-up patient at high risk. Low priority is who has the cellular clinic follow-up, who have completed long-term treatment or some other screening procedure, psychological support, nutritional support. Those can be done through teleconsultation, need not to come to hospital. Imaging priority again, yes, if you if the patient is responding clinically, you can avoid the imaging, you can go ahead with X-ray, and if possible, you can delay your imaging techniques. So like for the follow-up patient, for the stage 4 patient, you just clinically, for a stage 3 or stage 2 patient, whether the patient is doing clinically, you no need to do any follow-up scan after the gradual treatment. You can delay that and follow up with clinical parameter or telephonic consult. So again, the imaging priorities, not go details. Surgical part, where possible you can use SBRT, where possible you can delay the surgery, or you can do a sequential neoadjuvant chemo followed by delaying in surgery. But where the surgery is imminent and this is the only mode of treatment, you have to do it. It's a high priority. Medium priority is discordant biopsy likely to be malignant, or you know that this is a high probability benign. You can defer that therapy. Resectable non-small cell lung cancer, a T1 lesion. It's a medium priority. You can wait for 2-3 months. Diagnostic or for probable nodule, again it can delay to some extent, or you can do alternative stereotactic radiotherapy in place of surgery. But the low priority is very tumor, those under screening and a corporate checkup, benign tumor, patient is only on diagnostic workup, on follow-up, so that can be low priority and can be deferred. So early stage lung cancer, high priority, we have discussed. Stage 2, stage 3 tumor where surgery is important, either surgery plus chemotherapy, you have to go ahead. Use the growth factor support liberal to decrease the febrile neutropenia. Medium priority we have discussed whether chemotherapy can be given 2 cycle in place of 4 cycle, then surgery can be delayed. And no follow-up is required between chemotherapy cycle if the patient is doing well. Early stage low priority is adjuvant chemotherapy for patient without any significant benefit. Patient has a high comorbidity, old age, so you can defer or you can avoid chemotherapy. Locally advanced high priority concurrent sequential chemoradiation, you cannot stop that. Starting development of slightly later within 6 weeks. Neoadjuvant chemotherapy can be given and surgery can be delayed. You can do that for a stage 3 cancer and growth factor use. Medium priority, again, follow-up can be postponed without between cycle. You can just see once before chemotherapy cycle. No blood check is required in between. High priority for metastatic lung cancer, curable disease, those on TCO or immunotherapy, mutated lung cancer, driver mutated, you have to treat them, but you can do a longer follow-up, and in between you can do a telephonic consultation. If you are using chemotherapy or chemoimmunotherapy, use the liver, use of growth factors. And what we have suggested also, those candidates who are candidate for a chemoimmunotherapy, our suggestion is that first you give 4 cycle of chemotherapy, and if the patient is doing clinically well, then you can use immunotherapy as a maintenance, because we have seen that chemoimmunotherapy has a higher side effect in an initial cycle. So you want to avoid that during the pandemic. So you can customize your therapy. Medium priority is those patients for small cell extensive stage where chemotherapy is the only options. Low priority definitely where patient is a immunotherapy having side effect, not fit for patient. Like we sometimes give weekly nab-paclitaxel in a PS2 elderly patient, single agent pemetrexed. So those patients can be avoided where you believe the chance of chemotherapy toxicity will be much higher as compared to the life year gain and the quality of life. And all the supportive therapy, ordering as a blood transfusion, that can be deferred or it can be done at home by the home physician or the physician nurse. So these are the SCO recommendation for COVID-19 positive and suspicious patient. We have already discussed. So the main implication is where you believe that the attention is required for a particular patient, curative patient, you should do it. You have to prioritize, you have to discuss with the patient, what the patient is coming, A financial state has the logistic support that everything has to be discussed, need to be prioritized, need to be discussed in NDT and take that call. And adjuvant therapy, whenever there is borderline indication, you try to avoid or try to delay. Surgery can be delayed where it is permitted or can be deferred where neoadjuvant chemotherapy can be achieved. You can, for immunotherapy where it is mandated, you can increase the gap of the immunotherapy. So this is how we treat these patients. So these are all the targeted therapy available in current treatments, and we have immunotherapy. We have lots of chemotherapy option also. So thank you. I'll stop here. Back to the organizer.
Thank you so much, sir. So with this, I think we have come to the end of all the presentations. So before we end this, we'd like to know all the participants who are attending the webinar. They'll be getting an email shortly from the dashboard for downloading the certificates as well as for giving their feedbacks for the webinar as well. So before we end this, again, we'd like to thank Dr. Biswas sir for the beautiful and informative presentations, Dr. Sri Krishna Mandal sir for the beautiful presentation as well. And we'd also like to thank BI for their support in making this webinar possible. So we'd like to know, let everyone know that we'll be coming up with more interesting and assuring webinars in the future as well. Till the next time, again, we come to the end of this webinar by thanking Dr. Bivas Vishwas sir, Dr. Sri Krishna Mandal sir, and VI for sponsoring this webinar. Thank you very much.
Thank you all.
Thank you.
Stay safe.
Thank you.
Take care. Thank you. Thank you.
Thank you, sir.
Thank you. Thank you.